So the next part of this meeting is our session on global issues in MCBK. And in this session, we will be leaping time zones and virtually traveling around the world from the UK to China and then to Australia. We thank in advance our speakers for being awake at ridiculous hours of the day. We so much appreciate that. So we have three speakers whom I will introduce in a moment. We have Philip Scott, who will speak first, and I will introduce him first. Each speaker will speak for approximately 10 minutes, and then are we having Q&A at the end, Rachel, or are we doing Q&A after? Okay, so after all three speakers speak, we'll have a Q&A session. So please, as the speakers are speaking, feel free to put your questions and in the Q&A, and we'll get to them at the end of the three presentations. Our second speaker will be Guilan Kang from Beijing, where I think it's 3 in the morning. And our final speaker will be Enrico Coiera from Sydney, Australia, where I believe it's 6 in the morning. So thanks to everyone. Well, let me begin by introducing Philip Scott. Philip is a reader in health informatics at the University of Portsmouth and digital healthcare architect of Portsmouth Hospital NHS Trust. He's the deputy editor of BMJ Health and Care Informatics, serves on the boards of the PRSB, and he'll tell us what the PRSB is, and HL7 UK, and chair of the FME Evaluation Working Group. Philip has worked in health and care informatics for over 25 years, and Philip is a great friend, colleague, and supporter of MCBK, who was instrumental in beginning the MCBK work based in the UK. Philip, thank you and welcome.
Thank you very much, Chuck. It's a great privilege to be here. So you've introduced me. The only thing I would add to your introduction, so first of all, PRSB stands for Professional Record Standards Body, and that's an umbrella body that brings together all of the medical royal colleges and the other healthcare professional bodies involved in setting standards from a clinical perspective. And the other group I'm involved with is specifically the joint working group we've set up to lead the MCBK work in the UK. And that's been established as a joint working group between the BCS, where I chair the Health and Care Group, and the Faculty of Clinical Informatics. And Jeremy Wyatt is the co-chair, and we work very closely together. So what I was going to talk about is, first of all, who we are, then a bit about how we present the message, because I think we found a recurring theme is the acronym MCBK doesn't immediately resonate in people's minds, and we have to kind of explain what we're talking about. A bit about what we've achieved so far, and then something about our future plans. So who are we? Well, we've managed to bring together a pretty good coalition of interested parties. As I say, it's jointly led by BCS and the Faculty of Clinical Informatics. And very importantly, we have NICE, the National Institute for Health and Care Excellence, who are the producers of clinical guidelines, primarily for England and Wales, but also used more broadly in the UK, and Health Education England, who are responsible for all aspects of medical education and also for subscriptions to medical literature and knowledge services. And as Chuck mentioned, we also have HL7 UK as the standards aspect of this, and Health Data Research UK, which is, again, a national coalition with huge amounts of central government funding that's brought together a number of previously disparate research groups under a common umbrella, and they have done tremendous work, particularly during the pandemic. So I just wanted to describe kind of some of the ways that we present the MCBK message when we're trying to get people at senior levels to understand what this is all about. So this slide, courtesy of Jeremy, this is a slide he produced for some work that I'll describe later that we did with NHS Scotland. And so the point here is having a single set of algorithms that can feed multiple use cases, multiple apps, multiple devices, multiple EHRs. And so the box in the center is our library, that's our CBK library, and it could be feeding something which is for a resident in a care home, or actually self-caring at home, a nurse-run or social care-run service, or in general practice, or even in a hospital, or in preventional services. And so it's just this, trying to get across this basic idea of singular algorithms that can have multiple use. I've also illustrated it as a roadmap, and you might recognize in the background is the 14th century Mappa Mundi from Hereford Cathedral. And interestingly, they weren't actually saying that the Earth is a flat disk. They knew that even then. But it's a kind of a conceptual map of how they understood the world. But I think the simplicity of it does lend itself to our still relatively emerging understanding of how MCBK needs to work. And so using this map, it's to try and illustrate that at the top, we have the triple aim. That's what we're searching for in healthcare, the improvement of population health, the improved patient and citizen experience, and the reduction of cost. Can we achieve that magic triangle? And at the center, where the map had Jerusalem, we have the learning health system as the engine, the thing that makes that possible. But that's built upon a series of foundations: legal, regulatory, standards and governance, economics, the business model, trust and implementation. And so we're trying to get through to policy people that this is a complex problem. It's not a technical issue. This is something that has a huge ecosystem implication. And then finally, another LHS diagram that we've used to illustrate this a little bit more at the mechanistic detailed level is looking again at CDS libraries feeding electronic patient records, being used both at the individual patient level for assessment and treatment, and then at the population level for outcome audits, and using that data then for guideline reviews. So what have we achieved? If you were here last year, you will have seen this slide already, but in case you're new to this meeting, this is a brief recap. So we started back in 2019. I don't quite know how we did it now in reflection. We got a conference together by October 2019 in London, and we managed to get some of the reports published in BMJ Health and Care Informatics. We've got a set of videos on YouTube. But then, of course, after October 19, something happened, which has somewhat slowed our progress. But nonetheless, we have continued to do what we can. So we ran a project with Health Data Research UK. They asked Jeremy and I to lead a project on improving their knowledge sharing. And there were two aspects to this. One was the kind of informal knowledge sharing between the research groups to make sure they were getting the most out of collaboration rather than competition. And then I led the side that was looking at the more technical aspect of, have any of these research groups actually produced any knowledge objects that are executable and shareable? And so to test that, we ran what we were going to call a hackathon, but we ended up being persuaded to call it a collaborathon because that sounded more friendly. And so we got together various teams of people and we offered a choice. They could either take existing knowledge objects, some of which were written in clinical quality language, some in JavaScript and some in a FHIR-like JSON representation. And we also gave a set of scenarios for people to develop solutions against. And we provided them with a FHIR server and some synthetic data, and we provided tutorials on how to use FHIR, how to use CQL. We used the Dataphoria CQL engine as that's public access. We had got a patient lined up to participate, but unfortunately, being a patient, the person was ill and wasn't able to participate. So these were the two choices. Challenge one, implement a knowledge object. And we had one from Manchester University Clinical Practice Guideline Repository. That was the FHIR-like JSON. We had a CQL artifact from CDS Connect. And we had a JavaScript pharmacogenomic use case from Knowledge Grid. And then we had the four listed guidelines mostly from NICE, and there's one also there from BMJ Best Practice. So we ran the event on the 10th of December. We had great participation, and as you can see, the participants actually managed to produce some solutions. Even though some of them were undergraduates, they managed to pick it up pretty quickly. A couple of observations: that the research groups were more interested in producing knowledge than deploying knowledge. And that's, I guess, is the culture of research. And that there was a tendency that people were more interested in building their own than in deploying other people's knowledge. And I guess obviously, but worth restating, that the teams had to include both clinical and technical people to really make progress. That was followed up with a couple of blog articles on the HDR UK website, and the links are available afterwards. We then did a review for NHS Scotland of their decision support service, and we gave them some guidance on the direction of travel they were taking, and they're very keen to be in alignment with the MCBK ideas. And then most recently, we've had a group, I won't go through all the acronyms because of time, but essentially all of the NHS and relevant government central bodies have come together. They, at a senior level, now realise something does need to be done, and we're kind of shepherding through the process of understanding what it is that needs to be done. And most recently, I managed to highlight the learning health system in an editorial I was asked to write for the BMJ, commenting on the latest NHS data strategy. Which again, I think was a little bit of a missed opportunity in that the focus is just on the data, and they're not really quite appreciating the value of knowledge as a computable resource. So our plans, very quickly, we do want to run another conference either late this year or early next year. We're looking particularly at industry involvement and the regulatory aspects, and we are still working with HDR to see if we can help them develop a more explicit knowledge strategy about how to turn their research into executable knowledge. A final advert, if I may, for MedInfo 2021, where I'm co-chairing the Scientific Programme Committee. We've managed to get a stream into that conference on computable knowledge, and I hope that some of you may have submitted papers. So thank you very much.
For this presentation, and we are delighted to hear of all the developments in the UK that you and your colleagues have caused to happen. You might be wondering about the glasses. I should tell you that my progressives broke a few weeks ago, and I have substituted for them $10 glasses from Walgreens, which I must take on and off in order to be able to read, and even that doesn't work so well. So that's why I'm peering into these pages as I read introductions of our excellent presenters. Next is Dr. Guilan Kong, an associate research professor at the National Institute of Health Data Science of Peking University. She received her PhD in Decision and System Sciences from the University of Manchester in the UA, so a connection with Philip's nation, and a Master in Engineering and Bachelor's in Engineering in Computer Science and Technology from the National University of Defense Technology in China. Her research focuses on clinical decision support systems, medical data mining, multiple criteria for measuring medical quality, and learning health systems. With that, I will introduce and welcome Dr. Kong and her presentation.
Hi, everyone. I'm Guilan Kong from National Institute of Health Data Science at Peking University, China. My topic today is about mobilizing computable biomedical knowledge, which is abbreviated as CBK in China. This is the outline of my today's talk. I'll talk about the background and the purpose of CBK first, and then about what we have done to mobilize CBK in China. And finally, I'll talk about the opportunities and the challenges of mobilizing CBK in China. Background of CBK. Traditionally, we rely on medical education to equip doctors and nurses to transform medical knowledge to clinical practice. But there is a long time gap between knowledge and practice, and research shows that it may be 17 years long. In the era of big data, large amounts of data in medicine have been collected as routine, and different data-driven models have been developed. How to make these models shareable and reusable is a topical topic. At the same time, more and more scientific papers have been published. It is not realistic to rely on manual searching to extract advanced knowledge from the literature. How to make this type of knowledge computer readable is another challenge for researchers. Overall, in a learning health system, which is abbreviated as LHS, how to use a common platform or tool to package various types of knowledge, including data models, algorithms, and rules extracted from the literature, and to apply them in practice to support clinical decision-making is an important issue in medicine that needs to be solved. Purpose of CBK. First, through CBK, we can make various types of biomedical knowledge computer readable and actionable. Second, through CBK, we can make various biomedical knowledge easily findable, universally accessible, highly interoperable, and readily reusable, which is a fair rule for CBK. Finally, and most importantly, we can use CBK to support clinical decision-making in real time and in a right way. What we have done to mobilize CBK in China. First of all, our team at Peking University has been trying to build an LHS in China. The target medical problem of the LHS is about diagnosis and treatment of chronic kidney disease, which is abbreviated as CKD. The scale of the LHS is the district of Ningbo City in Zhejiang province in China. The learning community we built for the LHS include researchers, CKD patients, physicians, and admins from local healthcare authorities. The knowledge source of the LHS include not only real-world big data, but also clinical guidelines and related literature. The data source of the LHS is the real-world big data from the local regional health information platform. The focus of the LHS is on connecting data to generate knowledge and applying the knowledge to improve practice. My topic today is mainly about the process of transforming knowledge to practice. For the purpose of applying knowledge to improve performance, we have done some important work in China. First, we have localized the knowledge grid platform in Zhejiang for packaging, sharing, and real-time calling of clinical rules extracted from guidelines and literature, and data models developed from real-world big data. The platform was developed by the Learning Health Sciences team and at the University of Michigan Medical School, and we have got lots of technical help from the Michigan team during the process of localizing the platform in China. Second, to make the advantages of both domain knowledge and the data models derived from real-world data, we have been developing an evidential reasoning rule-based methodology to combine domain knowledge and data models in supporting clinical decision-making about CKD management. Third, to validate the LHS for CKD diagnosis, treatment, and management, we have selected a clinical scenario for CKD treatment to test the feasibility of using CBK objects implemented on the knowledge grid platform for clinical decision support in practice. We plan to do the system validation in the next 3 months. Here, I cut 2 screenshots of our local knowledge grid platform. The left one is the homepage of our localized platform, and the right one is the interface provided by the platform for acquiring clinical inputs about a CKD patient with anemia, and then provide a treatment recommendation for the patient. The background domain knowledge of the CBK object were clinical rules extracted from KDIGO guidelines. About the methodology we proposed to combine domain knowledge and data models is the ensemble approach. In this methodology, we employed belief rule-based to model domain knowledge. We used traditional machine learning algorithms to develop data models. And finally, we used evidential reasoning approach, which is abbreviated as ER approach, to combine inferred results from both models. In this methodology, inferred results from each model was considered as one piece of evidence, and the ER approach can combine those evidence one by one. At the same time, our team has developed an EMR-based computable phenotype for CKD identification. In the computable phenotype, we used not only diagnosis narratives and ICD codes, but also lab tests to identify CKD patients, risk population, and no CKD population. And for platform validation, we have determined to use a clinical scenario for CKD treatment to test the feasibility of using knowledge grid platform to package knowledge and apply it for clinical decision support to improve practice. Finally, opportunities and challenges. About opportunities, healthcare quality in China is desperately needed to be improved, and intelligent clinical decision support systems and LHS are very much expected in China. Second, amounts of data have been accumulated in medicine, and large amount of Chinese literature has been published. Invaluable biomedical knowledge is there. And third, CBK is a new concept in China, and we are the first research team to promote CBK in China. About challenges, first, CBK is a new concept in China. It needs time to get it widely accepted by the academia and medical community. Second, standardization of CBK platform or tools needs advanced techniques. Third, to support clinical decision-making, integration of CBK tools into clinical workflow is needed. but there are technical, managerial, and institutional issues about it. That's my topic. Thank you very much.
Thank you, Guilan, and for that excellent presentation. And we will now move on to our third presentation on worldwide mobilization of CBK. And we welcome for this presentation Dr. Enrico Coiera, Director of the Center for Health Informatics at the Australian Institute of Health Innovation at Macquarie University. Enrico is trained in medicine with a computer science PhD in artificial intelligence. He's foundation professor in medical informatics at Macquarie University and director of the Center for Health Informatics there, a group he co-founded in 2000. With a research background in industry and academia, he has a strong international research reputation for his work on decision support and communication processes in biomedicine. Enrico, thank you for joining us. I hope you've had your coffee, and we look forward to your presentation.
Thank you, Chuck, for that generous invitation. Yes, it is quite early here. It's the upside down. It's early morning. It's winter. And also most of my nation is in lockdown currently. Although we've done very well with the virus, we all get very paranoid, so no one's going out. Anyway, so what I thought I would do with my little postcard from Australia in the 10 minutes I've got is give you, like Philip, a little sense of what's happening organisationally in Australia, and then maybe some snippets of research from different groups across Australia that I think are relevant to the Mobilizing knowledge agenda. So the first thing to talk about, I guess, is the envy we have when we look across the pond to both the US and the UK for the level of government investment in AI and digital health. It's something that, for reasons that are still difficult to understand, have yet to happen here. But rather than moaning about it, we've got together a very large national group called the Australian Alliance for Artificial Intelligence in Healthcare, trying to grab the agenda and seeing if we can progress what needs to happen to get intelligent systems embedded within the health system on our own for now. And so the Alliance is about 3 or 4 years old now, and we actually have quite a large organisational membership. It covers our state governments. We've raced ahead there, I'm sorry. Our state governments, industry, lots of academia, and also a lot of health service professionals. And the object really is to bring together what essentially is a very small population across a large country in common purpose, to not duplicate, to not compete where possible, and to understand what we need to do to support each other in both undertaking the research as well as the translational work to get stuff out there. And although it's not been spoken about necessarily by others, we've got some big building block problems like building a workforce that's expert in computational systems and setting up regulatory processes in terms of safety and efficacy and ethics. So our current work programs are really around developing a national roadmap, which we hope to launch in a few months' time. And there is a glimmer of hope now that there may be some federal funding. And so we're working as an alliance to create a bid for a national centre for healthcare AI. So please pray to whichever deities that you believe in, and we'll take whatever you'll give us. Now, to the research, and this is going to be very brief, but I thought I would identify an arc of research across the country that I think is of great relevance to you. And the first part of the work really asks the question, where do our computable models come from? And the first part of the answer is, well, they obviously come from the published literature. And so for a while now, we've been looking at this issue of whether or not we can take the traditional process of systematic review and use computational tools to transform that into an automated process. And if you step back, you'll think of systematic review really as very many steps. And you can break them down into quite small, granular steps. And most of those steps are automatable. There are a few that are still a bit difficult, but by and large, you can automate most of it. And what's exciting is towards the bottom of that stack, you start to create computational representations of clinical trial papers, and these become computable objects. And this is not just pie in the sky. Paul Glasio and his team in Queensland undertook the first automation-supported systematic review just a year or so ago, and they've now done about a dozen of these. And as you can see, they've completed them in 2 weeks was the first one, and they're much faster now with quite small teams. And if you're a systematic reviewer, you know this is a very fast process. So it's gone from an idea to people actually pushing on with doing it. And I find that very exciting. But it's not that we have total agreement nationally. You know, Adam Dunn and his group at Sydney Uni across town from me have had a very different view, which some of you might remember also was a view, I guess, embedded in Ida Sim's early work on computational models of clinical trials, which is the idea that, you know, maybe our computable models need to be extracted from raw trial data in trial registries, and we shouldn't be worrying about the literature. And these two warring tribes really are now at peace because we've obviously realized that you need both, that it will be crazy to not remember what has been published in the literature and not to extract all that deep biomedical knowledge. But equally going forward, you know, computationally, it's going to be far more efficient to be able to work with those large trial data sets. Now, I want to move to a piece of work that we've, in our own group, completed quite recently. It just came out a week or so ago in JAMIA, which asked the question whether if models come either from the literature or the data used to create that literature, how do we know the models are right? How do we actually know what we've built is something that will work in clinical practice? And our approach to looking at this was to undertake a replication study. In other words, to look at our current state of computable knowledge, which is in decision support systems, and to see how well we test them in the sense of replicate it. Can somebody independently take a decision support tool and replicate its performance in a different setting? And as you can read from the slide, the story is not a good one for health informatics. We found about 4,000 CDSS papers, but we only found 12 papers out of 28 medical informatics peak journals that were replication studies, so 0.3% of the literature. Now, I just need to point out that in psychology, where they panicked about having a replication crisis, they had 3 times that rate in their pre-panic level of literature. So we really have a problem here in the sense that we don't independently validate academically the work that we do. The other part of the story that's really important is this notion of what testing of a model means. Are we testing that the model is correct, or are we testing whether the model generalizes to other settings? What I've got here is a heat map for 6 studies of a very famous paper by Hahn, which found that CPOE increased mortality, and that we found 6 replications, which all repudiated that study. And across the top, you'll see different levels of replication, from identical replication, which tests truth, all the way through to variations where we're just conceptually putting the same sort of system in. It's one CPOE replaced with a CPOE from another company, but they're not identical systems. And then on the left-hand side, you can see we graded things according to different attributes of the studies. And of relevance to this community today, I think it's around outcomes, it's around the design of the intervention and the population and the setting in which it is. And you can see there was a lot of focus on methodological replication, but most of the studies tested things in widely different areas, different health settings, different variations of the technology. So while there's some scientific comfort that the results are generalizable, it's very hard to know what the truth is of whether or not the knowledge embedded in that CPOE system really is true or not. So I just thought I would leave you with, I guess, a positive scientific challenge, which is that this notion of context transportability for our knowledge is a foundational challenge. You know, models are never correct. They never work in different settings in the way you would wish. And we need to be thinking about not just testing whether or not our models are correct in some arbitrary abstract way, but recognizing we need to be able to generalize them and modify them as they are embedded elsewhere. So with that, I'll stop. I'll thank you. And I think if I click the right slide, we'll get to Q&A.
Thank you very much, Enrico. We're tremendously appreciative of your and indeed all three presentations of our panelists today. We have a few questions, and I hope you're ready. The first comes from Bruce Bray, and this one is addressed to all three speakers. The question is, well, it's not a question, it's a statement of interest, which can be seen as a question. I am interested in the international speakers' perspectives on the key differences, both barriers and enablers, in implementing CBK in Europe, in China, and Australia as compared with the USA on your perception. So anyone who would like to start, please jump in.
I'll have a go. So, I mean, strictly speaking, we're not Europe anymore, but I'll mention it geographically, if not politically. Yeah, sure, there are differences in the way health systems are funded, the way health systems are governed, and clearly that has an impact in terms of policy priorities. Like Enrico was saying, the challenge of getting national level funding for AI and healthcare initiatives. In the UK, we currently are in a fairly fortunate position there, although some would argue it's just giving all the money to industry rather than actually getting, what we might think of as proper academic knowledge. So yes, there are differences, but then when we come to the actual front line and the practice of healthcare, I think the implementation issues are very similar. I think the fundamental issues, like Enrico's context transferability question, replication question, they're the same universally. So I think, yes, there are some political, economic, policy kind of level variances, but by and large, I think we're pretty much facing the same set of issues, in my view.
Thank you, Philip. Guilan or Enrico, would you like to comment?
Okay, thank you, Jack. I'll say something about the AI in China. I think in China, the healthcare system and the policy of healthcare is different. And for the research of AI in healthcare, it is a topical topic in China. So there are loads of funding in China to support researchers in applying artificial intelligence in healthcare. Although it's a little bit different from the concept of learning health system, but I think only the conceptual difference, maybe if our team and our colleagues in China make efforts in promoting learning health system and a CBK in China, maybe in the future, there are many more researchers will join us in the research of LHS and CBK. And maybe in the future, there will be some special funding to support the research, especially for learning health system and CBK. And yes, that's what I think.
Thank you.
Yes. Yeah.
Thank you, Guilan. Enrico, would you like to go with this one?
Sure. Just to add a topic that is starting to get our attention is this notion of algorithmic sovereignty. In other words, do we build our own algorithms and do we have the capability locally to develop and deploy, or do we import? And there is a great concern really that countries like Australia, which just may not have the resource to do what we want to do, end up importing from Epic or Cerner, not just their systems, but also their algorithms, probably harvested from the data that we have here locally. So we become an exporter of data and importer of algorithms, which will be a disaster in terms of both national sovereignty and control, but also in terms of security. And also the algorithms may not actually be fit for purpose. You know, the populations, if they're built on overseas populations, may not quite match who we are. So there is now a growing argument about not just the need to have these sorts of technologies implemented, but really who gets to build them and what are the national scale implications of either owning your own capability or being reliant on large multinationals.
Thank you. Thank you very much, Enrico. So I just want to interpose a question here of my own, and this will go to a discussion we're going to have tomorrow morning about MCBK as an organization for which, given the time, I don't expect Guilan or Enrico to be participating. How can we work together? If MCBK becomes a membership organization of some type, how do we engage with you? Would you like to engage with us? Do you see this becoming a global enterprise that would benefit from an organization with global scope? Anybody would like to take that on?
I'll have a go. I think there's a couple of different models. I mean, I've had experience with HR7 where we have affiliate memberships, but the reality is most of the action is US centric. And until the pandemic, the majority of the meetings were held in the US. I think the fact that we've been able to continue making progress virtually demonstrates it can be done. The downside is what we're experiencing now with Guilan in the middle of the night, Enrico in the early morning, and me getting ready to go to bed. So I think there's some practical issues about rotating time zones. We have the same on the journal editorial group where we have an international group, and it's the same with anything we try and do globally, isn't it? You either all go somewhere, or people are up in the middle of the night, and you've just got to choose one or the other, or a mixture. So yes, it definitely should be global. I think there's a question about how close the connections have to be. I think there's a clear desire to work around this principle, this concept of computable knowledge libraries. I think, as the previous question raised, there are legitimate differences. So I think there's a balance to be struck in terms of not being overly prescriptive, but equally gaining the benefit of the synergy and the collaboration where it exists. So I think there are some natural collaborations which will come about through some of the working groups. So we're looking, for example, at setting up some more specific working groups under the MCBK umbrella. So I think that kind of needs to evolve a bit. I don't think there's an obvious blueprint for it. There are some things we can learn from HR7, from SNOMED CT, and other bodies of that nature. But I think we also have to recognise the embryonic nature of this and allow it to kind of find its own feet and grow a little bit naturally.
Thanks so much, Philip. Enrico or Guilan, would you like to comment on globality?
Yeah, Chuck, I think we'd be very keen to participate. I can imagine the Australian Alliance being a natural partner there. I do like the idea of topic-specific working groups, and I'm also very conscious that we can be thinking regionally. So Asia Pacific, China, Australia, Japan, all sort of share the same time zone, and things can be rotated through time zones too. So it's possible to do that. I wonder, Chuck, if you've thought of a global Kaggle-like challenge. You've obviously, Philip talked about having a UK challenge. The idea of maybe having global teams come together to sort some of those challenges might be a way of building relationships rather than having countries work individually. Let's see if we can put some global teams together.
Thank you, Enrico. Guilan, any comments on this matter from you?
Yes, and we are very happy. We have already been part of the MCBK. And in China, although it's a new concept, but we have been trying to build a community from academia and industry and to promote CBK in China. And although it's still in the process, and it is a little bit slow due to the COVID-19. But I think maybe in the near future, we will build a community about CBK in China, and then our colleagues in China will show their efforts and their research and their practice of mobilizing CBK in China, and we'll have more to talk about maybe in the next annual meeting. And yeah, that's all. Thank you.
Thank you, Guilan. We are, unfortunately, because we have a few more questions at the end of our time, Brendan Delaney has a question specifically for Guilan, which I hope she will be able to answer offline. And I'm sorry we are not going to get to the other questions, but I thought this topic and the views of our excellent colleagues from around the world on how MCBK as an organization could promote global collaborations were very, very important. So I took the prerogative of the chair and interjected that question. So this brings this session to an end. Let me thank our three superb panelists once again, and to bring the plenary part of MCBK today to a close, I'll turn things back over to Rachel.